Hopefully the sound isn't muffled. I've been having some sound problems, but as you can see, I've got my little distraction here today too. So hopefully we can get through it without too much problem. So I wanted to go over some respiratory distress stuff with y'all. We talked a little bit about some respiratory stuff before, and so I want to just go over a little bit of the treatment stuff. So I've got some stuff. Now basics, you won't be able to do all of this, but I really just wanted to show you how to do some stuff hands-on. So remember we talked about a patient in acute respiratory distress. They will be having some intercostal muscle use, retractions, maybe tripoding. When you listen to their lungs, and we always listen to their lungs, right? Right. You may hear wheezing, you may not. You may just hear coarse lung sounds. You may hear rhonchi. You may hear rales. So with rales, you will hear kind of like they are, when they breathe, it's almost like blowing air through a straw into water. You kind of hear that bubbling sound, and it's most likely decreased. You never can really hear it very well. When they've got bronchi, it's like a real coarse, hard, almost like a pleural rub sound. And then we know with wheezing, it's wheezing. It's that high-pitched sound. I'm not going to try to make it today. So, what do we do with a patient that's having respiratory distress? Usually their oxygen sats will be low. I actually brought the monitor out here today so I can show you my handy-dandy favorite tool, the ETCO2. And I brought some meds. I think I said it before, basics won't be able to do all of this, and there's some stuff that even the advanced can't do. However, I brought it so that way you know what to expect, you know what's going to help, and you can be a better partner for that paramedic that's got to administer it. You know what's going on. I mean, it's amazing when you have a good partner that can help. So, I also brought an oxygen tank, and we are going to go hands-on. I wish that you guys were here, and some of you guys have done this with me, and some haven't. So first, let's talk about, you get on scene, it's a patient in respiratory distress, obviously having shortness of breath. We're going to say no chest pain, no cardiac history, but a history of asthma. So you get an O2 sat, maybe it's 94. You also listen to their lungs, right? And you hear wheezing, which is a lower airway problem. So you immediately know that you've got to give them a breathing treatment, right? So one of the best things you want to always remember to do is get a baseline. So before you start any interventions, get a room air oxygen saturation. I am going to try to put this monitor right here, so that way you guys can see it. So watch out, Gracie. You turn the monitor on. Here, please come over here. You turn the monitor on. You put them on that pulse ox. And there should be a pleth. And I have been recently studying about the pleth. And it's actually, so these right here is the throbbing of your aorta, and it shows how much hemoglobin is being carried to your extremities. I will actually do another video on that as well as CPAP soon, but we're not going to get into that right now. So it's saying that I have 96 oxygen, 95, but I don't really believe that. I'm gonna switch fingers because I am not having any trouble breathing, and so here we go. That's more better. More better. That's better. Okay, so heart rate, respiratory rate, and for us this automatically comes up. This is paddles. When you put them on the monitor, we'll change that, but we're not going to get into that right now. So this, I'm just going to take that off for a second.
It's a breather.
This is my favorite tool ever in EMS. I got a little echo back here. So this little thing measures how much CO2 you're letting out, and of course the patient is not going to like it because it's going to get a little bubble in their mouth. It's going to get in their mouth, and if they've got a runny nose, it's going to get snot on it, and inevitably that's going to happen. So I recommend having a tissue or a washcloth around, because especially when you start giving them a breathing treatment, it's going to open them up completely and things are going to get watery. So you plug it in there. Down here is going to be I'm going to put it on me. So you put it in your nose and then you tighten it. And see, this is the wave. Always make sure to press print, and that records it for your file. And I'm going to do a little bit of stuff just to see how it goes up and down. So of course, it's probably going to look backwards on your screen, I'm sorry, but the normal is 35 to 45, so mine's at 42. This respiration rate is not always right. It's saying I'm breathing 29 times a minute. That is not the case.
Yes.
Make sure to count your patient, not the machine. So when someone, so 35 to 45 is the normal, and you'll see an open wave. I'll breathe normally for you so you can see what I'm talking. So I'm gonna print that real quick. Okay, so you will see this open waveform. That's inspiratory. This is actually your expiratory. When it goes down, that's your expiratory. No, that's your inspiratory. And then, let me make sure I'm doing it right. Yeah, when it goes down, that's your inspiratory, and then this is your expiratory. So with the open thing, you'll see that it's open. They're breathing fine. If they're having wheezing, you'll see it look like a shark fin. And I mean, I'm not just saying this because I'm a little bit obsessed with sharks. Like, it legit looks like a shark fin. You will see a really weird pattern. Let me see if I can create it. If you see a pattern like that, that means that they're kind of rebreathing in a way. Let me put that back on because it'll say apneic. But that means before they can get their air all the way out, they start breathing in again. And that's usually a sign of a respiratory problem. So let's mess with the CO2 a little bit, right? So if a person is breathing really fast, it's going to bring that CO2 down. So watch. Sorry you guys had to hear me do this, but well, it's supposed to bring it a little bit. See, it went down to 33. Now, if a patient is not breathing very fast and they are bradypneic, tachy means fast, brady means small, so remember that. So let me stop breathing here for a minute. So see how it jumped up to 40? So people with sleep apnea, you might pick them up. I'm going to shut this off because if you get it off, I'll let you just see. If you get it off the patient for a minute and it's sensing that that patient's not breathing, it's going to set off a god-awful alarm in just a second that says, hey, your patient's not breathing. So, I mean, that's a good indicator, too. You can see how well and how effective your patient's breathing. Well, it should say, this means no breathing. There will be an alarm soon, but I will actually stop it before it does. Okay, so that was a quick little thing. Remember to leave that on the patient, even if you're doing a breathing treatment. Underneath that mask or underneath that non-rebreather, leave it on the patient because it really does tell you so much about their breathing. And if they're breathing shallow, you can still see how effective it is because of the numbers and the pleth on the CO2. Okay, so that's a little down and dirty about that. Let's talk breathing treatment. Uh-oh, sorry. So, there's Bear. She's messing with some breathing stuff right now.
Oh, there it is.
I'm gonna walk across the screen for a second, y'all. Okay. Got my oxygen tank. This one's super easy. It's all off right now. I'm gonna twist it till you see that green on. That's the top. You can control the flow rate. So, if that patient is on home albuterol or they just took a breathing treatment, you can skip to duo-neb. However, a basic cannot do a duo-neb. They can only do a single albuterol. They can do an albuterol treatment. So, what we're going to do is set up this neb mask stuff for you. So this is what the packaging for albuterol is. I always try to remember that blue is albuterol. You open it up, it's this nifty little clear thing. And so inside the neb package, you get a pipe. We like to call this a peace pipe. You get a reservoir and you get tubing. You also get a T adapter and a mouthpiece. You'll see what that is in a second. So, if that patient is having difficulty breathing, you're going to empty this packet into the reservoir, however you say that. And then, whether you use a mask, it's technically called a venti mask, for it, or a peace pipe. So what I did was put this mouthpiece on the T adapter, and then
You can put this in a way.
you hook up the peace pipe to it. We've got the medicine in there, and you can either do that, and they could do it like a pipe, breathe in and out with it. A lot of patients prefer that if they have like problems with having something over their face. But if they're in real bad respiratory distress, I definitely recommend the mask. You hook the mask onto there. Then, easy way to remember, it's blue right here. You use that blue tubing. Hook it up there. You hook up your oxygen. And my preferred flow rate is 8, but it's really, I think technically it's 8 to 10 or 6 to 10, but 8 is a really good, flow rate. There, shh. Okay, so then, again, I'm going to use myself as a guinea pig. You put the mask on the patient. Make sure, make sure that you've got it good, that it's not stuck in their eyes. You can adjust this nose clip. Put this bad boy back on there. Be careful. You probably can't hear me. Be careful putting the flow rate too high because the oxygen tube will actually pop off and you don't want to do that. So, you got it over their mask. You're going to turn it to 8. Like that. They're going to breathe in. Just normal. Tell them to breathe normal. They'll get more of the medicine that way.
We'll turn it off.
And you will see that it's vaporizing. You want them to breathe in as much as you can. Some little side points. If you're doing it to a toddler or a little baby who will freak out if you put something by its face, have mom. It's always a great idea to use mom because it soothes the kid. Have mom hold it by their mouth, or you can do blow by. So what I like to do if it's a kid is I will tape one side so that way it's not coming out the other side, and they put it by the kid's mouth. They talk to them. I have been known to sing to kids. I've given them my phone so they can watch things. Anything to get that kid engaged. Usually mom is the best bet. You hold it by them, and as they breathe in, they're getting that medicine. So what this medicine does, as we talked about in it works on the beta 2 receptors. So it opens up the bronchioles in the lungs and help oxygen exchange and help the work breathing a whole lot better. So it opens up those bronchioles, helps the alveoli do their work. So let's talk about a little bit of side effects. Can you switch me chairs? So some side effects of albuterol. A good way that I always remember is pant. So remember pant like a dog because they're having problems breathing. I know it's weird to say that, but it's palpitations, anxiety, nausea, and tremors. You will realize that that is normal. Their heart rate will probably increase, so don't be alarmed at that. And they will feel like jittery. I don't know if you've ever had one before. I've had a couple, and it makes me almost feel like my skin is crawling. So for the second one, and the first one usually goes like within 3 or 4 minutes, 5 at the max. It goes fast, so watch. And then, let me get up again. Try to show me as least as possible in this video, y'all. Okay, so remember blue, albuterol. Purple, Atrovent, also called ipratropium. You add those together, have them, it's called a duo neb. Or if you go to a nursing home, they call it a dewy neb, and it just makes my skin crawl. I don't know why, but you put those together, you have that patient do that. You do 3 of those. And then, for advanced, I need that sodium nitrile. You start an IV, and then you give them this bad boy. This is, I don't know if you can focus on it, this is Solumedrol. It is a corticosteroid, so it is long acting. It actually does not even begin to work. It doesn't even begin to work for about 40 to 45 minutes, but we give it because the patient needs it, and the faster they get it, the sooner it gets in their system, the sooner it starts to work. So, there's a little stopper up in there. I don't know if you can see it through that. See that little plug? And it blocks the powder from the liquid. So what you want to do is, I'm going to set that there for just a second. Three cc syringe. Make sure that needle is tight on there. So you're going to press on that top thing. It's going to release the stopper. Some people shake it. I do not shake it because it makes bubbles. I go in a little circle. I mean, you still make bubbles, but it's not nearly as bad as shaking it. So you go into a circle until it is all dissolved. And then there's this little cap up here. Pop that off like that. A good thing to do if you're drawing up medicine is you pull back however much medicine you're going to give. So this is actually 125 milligrams per vial. So I usually just pull it back some. And there's a little, I don't know if you can see it, but there's a little bit of a circle right here to insert your needle. I always insert it like this, just however you do it. Be careful. Sorry, I'm not doing that really well. So I insert it until you can see the bevel of the needle, but you don't want it too far up. You insert that air, and then what I like to call magic, it starts to fill that syringe for you. So then you pull out all the medicine. We always pop that cap, because safety first, right? And then you administer 125 milligrams of Solumedrol in 2 milliliters of normal saline. And then that gets on board for that patient. Now, and I'm pretty sure this one is a paramedic. This next one is a paramedic thing, but I still want to show you because I like you guys to know everything, and this is one of my favorite drugs. Wonderful mag sulfate. So it's a smooth muscle relaxer. And it will help patients who are having irretractable wheezing, meaning that wheezing is not stopping. Usually, if they're still getting albuterol and Atrovent by my second breathing treatment and they're still wheezing really bad, I'm going to bust out this bad boy and give it to them because it helps like a champ. So, the dose for this is 2 grams in 100 milliliters of normal saline over 10 minutes. So, to mix that, and I apologize, I do not have a drop set up. Remember, 60 drop set for medication, 60 drop set for medication administration, which this counts as, and 15 drop set for fluid administration. So, we are going to, and this is D5. You could actually use D5 or normal saline. They can be interchangeable with this drug. So the concentration for this is, let me find another thing, 5 grams per 10 milliliters. And I might have said 2 milligrams, but the dose is 2 grams. So we need 2 grams. So 5 milligrams in 10 milliliters makes it a 50% dose, right? So if we want 2 grams, we want 4 milliliters. So we're gonna drop. Oh, I need a. Hold on. My daughter lost my syringe. So I'm going to use this 10 cc syringe because these only go to 3 and we need 4, right? So we're going to, I'm going to step out of that video. I'm going to use this needle. I recommend using a clean needle, but they're interchangeable. I'm going to attach this to an empty flush thing. Because reduce, reuse, and recycle, right, kids? That's what Captain Planet taught me. Anyways, so we're going to draw up. Remember I said I'm going to put 4 milligrams up here. And I'm going to draw up. Insert 4 of air. Well, this isn't vacuum sealed, so. Hold on, Bear. I'm drawing up 4. Oh, it's taking forever. It's thick stuff. Okay. So I got 4 of mag sulfate. And then I did that. I am going to use this handy dandy bag right here. There's a medication port that you can put right there. That is right there. So that way when you put medicine in, it doesn't make stuff leak out. So I uncap, and right here is where you put the drop set. And it says add set right there. So hopefully you won't get confused. But I am going to inject this mag sulfate. Keep getting in the camera, y'all. I don't like that. Gonna inject this mag sulfate into the bag. Like so. And then I'll pop this, because right, safety first. And then I always swish. I don't ever shake. I'm a swisher. I like it shaken, not stirred. Or no, stirred, not shaken. That's it. But then you're going to put your drop set in there. And then you're going to hook it up to the patient. And you will be amazed at how much mag sulfate works. It helps them feel better. Then by the time usually they get to the hospital, then they don't want to stay there because they're like, oh, I'm fixed. Because you help them breathe better. I love that stuff. Okay, so that's a quick respiratory distress protocol. I want to show you one other thing, and then I'm going to go because my daughter keeps texting me to go to the bathroom. So, non-rebreather. You've all put one on by now, hopefully. So, I just want to show you a little trick. They call this a non-rebreather because you're not supposed to rebreathe your own, it's supposed to be a closed circuit. So, a trick to make it a true non-rebreather is, you see there's that little, O-ring thing right there, and there's one right there. Especially for COVID patients, I do this because you pop this on this empty one right here, like so. It covers the holes. Then that's a true non-rebreather. So that air isn't really coming out of this like it was before, so it helps the germs and the droplets. Know what I mean? So, I know that was a little bit hectic, especially with my daughter, and I very much apologize, but I just wanted to give you guys a quick video to show you. We'll be doing more hands-on skills with this. Please get in touch with me if you want to come to the training lab. I'm always for it. My daughter's always for it. She will break you into the lifestyle of distractions on scene. But anyways, stay safe. Know that I really appreciate you guys. I see that you're doing hard work. Keep up the good work. And, all that good stuff. Free Joe Exotic. Something like that. All right, thanks.